Hello and welcome to Learn from the Case. Today I want to awaken your curiosity with a new neurological case. I want to talk to you about stroke. I prepare a presentation in 4 parts. This is part 2 of 4 them. I present some cases and make a first approach to the issue of stroke. So here we go. Rosita, 49 years old, and Nicholas, her husband, 55 years old. These are, of course, not their real names. Were watching a series late at night. They were sitting at the couch and he fell asleep. Rosita lets the episode end and waking up to go to bed. He goes to the bathroom first, like anyone would do, but it takes a long time. She goes to the bathroom to ask him what's wrong and sees that he's lying on the floor and he doesn't seem asleep, but he doesn't seem communicable either. She can't communicate with him. He says things that she doesn't understand. Sometimes he speaks very quietly, and when she listens to him, he doesn't say words that she understands. She reacts and calls the emergency services. The ambulance arrives about 15 or 20 minutes later and is already prepared to take him with a stroke alarm. There is no link to a website about this. It is a case that I attended to personally. Just like with other aphasias, global aphasia is most commonly the result of a stroke in the middle cerebral artery that supplies blood to the lateral surface of the left hemisphere of the brain. Not surprisingly, lesions necessarily for a persisting chronic global aphasia are generally quite large and encompass large portions of the left perisalient region. I show here MRT pictures, but it is not from the current patient. I just looked for some pictures that could be his. I mean, pictures with the stroke in the middle cerebral artery, but this is actually the right hemisphere in these pictures. Lesion typically involves a large portion of the left hemisphere. So the ambulance came and stayed for a while, so we had time to do an emergency X-ray to have access to direct onward transport to the thrombectomy center in case it was necessary. It had been less than 2 or 2.5 hours since Rosita called the ambulance, and she was in the toilet looking for Nicholas about 20 or max 30 minutes after he went to the toilet. The CT brain already started to show a shadow corresponding to a stroke in the middle cerebral artery territory, but no bleeding signs. He underwent thrombolysis and returned to normal very quickly. He was in the intensive care unit and I was called from the medicine unit, so he was taken care of by an anesthetist, so I can't say how quickly he regained his mobility and speech, but it was fast. Usually I like to stay and see when is a patient that is undergoing thrombolysis, but it wasn't possible in this case. It is almost always very fast when the right patient comes to thrombolysis, and very nice to see and witness that improvement. But anyway, both he and Rosita, who beside him, were very happy the day after in the stroke ward. He changed his lifestyle, tried to be a little more active and exercise or walks more, and stopped snuffing or using snuff. Snuff is a type of smokeless tobacco that is made of finely ground or shredded tobacco leaves. Snuff is placed in the mouth behind the upper lip. He rarely drinks alcohol now and takes very little when he does. Atrial fibrillation was identified, and that was also treated. Don't actually remember what he got, but sure liquids would think. He also takes aspirin, clopidogrel, bisoprolol, and atorvastatin. Enalapril for high blood pressure was also given. His blood pressure was uncomplicated to treat actually. Now, this last case reminds a lot of cardioembolic stroke. He was sleeping on the couch, and when he goes to the bathroom, gets the symptoms. As I said before, most embolic events occur during typical activities of daily living, but some embolic strokes start during rest or sleep. Sudden coughing, sneezing, or rising at night to urinate are also activities that are known to precipitate embolism. Here is one for stroke classification that we talked about in the previous video. The pulmonary veins are a potential yet infrequent source of cerebral emboli. This is reflected by the occurrence of cerebral abscess in association with pulmonary infections and in association with cerebral deposits secondary to pulmonary carcinoma. A rare type of embolism follows thyroidectomy. There is no gold standard for making the diagnosis of cardioembolic stroke. The presence of a potential major cardiac source of embolism in the absence of significant arterial disease remains the mainstay of clinical diagnosis. When cardiac and arterial disease coexist, such as atrial fibrillation and ipsilateral carotid atheroma, determining the etiology of the ischemic stroke becomes more difficult. However, in many patients, history, physical examination, and routine diagnostic tests like electrocardiogram and finding on neuroimaging studies are sufficient to easily make the diagnosis of most presumed cardiac emboligenic condition, like atrial fibrillation, recent myocardial infarction, heart failure, prior rheumatic disease, and others. An important exception is paroxysmal atrial fibrillation, which can be detected by 25 to 48 hours Holter monitoring or telemetry when the patient is in the ward immediately after a stroke. Transthoracic echocardiogram can disclose structural cardiopathies like dilated cardiomyopathies, mitral stenosis, and other structural ventricular diseases and interventricular thrombus, vegetations, or tumors, and enables measurement of the left atrial size and left ventricular systolic function. Transesophageal echocardiogram is able to study the aortic arch and ascending aorta, left atrium, and left atrial appendage, intraatrial septum, pulmonary veins, and valve vegetations. Cardiac magnetic resonance and nuclear cardiology studies assessment of myocardial perfusion, and analysis of ventricular function may be useful in selected patients. Of course, there are patients who need treatment for both cardioembolic causes, such as atherosclerosis causes, as secondary stroke prevention. And we leave here for now. Thank you for your attention, and I invite you to see the third part of this presentation in the next video. Be well.